Good evening, everyone, and welcome to our teaching session, which is the Orthopaedic Academy in combination with Orthopaedic Research UK. This evening, I'm delighted to welcome Mr. Sharma, a consultant at Luton and Dunstable Hospitals, for our talk on proximal femoral fractures. And I'm accompanied by Hani and Imogen and Hannah from the OR UK. My name is Nikki Evans and I'll be your host for this evening. We apologize for the slightly late start, but we're going to proceed with the lecture shortly. Then we're going to follow with some invited questions. So if you do have any questions for Mr. Sharma, if you would put them in the chat and we'll keep an eye out and we'll ask him at the end. We will be doing some Viva practice for 3 candidates. So if you would like to partake in this, if you let Hannah and Imogen know, then we'll get your names for the end of that. We'll only have time for 3 this evening. It is quite stressful, but we do believe it's the best way to prepare for the clinical and the Viva section of the exams. So as always, we recommend our concise orthopedic notes as well as the OR UK revision books, which are invaluable. I use them in my preparation for the exam. And so without any further ado, I will hand you over to Mr. Sharma for the lecture. Thank you very much.
Hi. Hello, everyone. Sorry for the late start. It's because of me, some computer problems. Let me just today, I thought we would talk about proximal femur fractures, which is one of the most commonest things you come across in your daily clinical practice. By that measure, you would also find them in orthopedic FRCS exams. This is one of those topics that you would be considered to know in and out. So what I'm going to do here is, can everybody see me?
Yeah, we can see your presentation.
Great. So I thought I'll take you through a journey of a patient who comes through in our A&E. It's a very common thing. We see patients presenting to us with proximal femoral fracture. It seems like an everyday practice, but you will be surprised to see how much controversies and how much evidence-based practices we undertake in that small journey that this frail woman is going to take through your hospital. I'm sure this is occurrence everywhere in each of your hospitals. So myself, I'm Amit Sharma. I work in Luton and Dunstable Hospitals, part of Bedfordshire Hospitals. That's my hospital, surrounded by a nice countryside. Now, let's talk about hip fractures. Everybody knows it's one of the commonest fractures that we deal with in trauma. The mean age in UK is around 83 years, and 2/3 of those are found in females. So as life expectancy is improving, we are expecting a global increase, rather a pandemic of hip fractures. So you might have something like a corona pandemic in 2050. It'll be hip fracture pandemic. Then there is a high risk of mortality associated with these fractures. So 1-year mortality is anywhere from 20 to 40%. 30-day mortality being around 8 to 10%. So you cannot change that in operation theater only. We are called orthopedic surgeons, and we believe we can solve all the problems in the theaters. But this is one fracture that cannot be changed. The mortality and the outcomes cannot completely be changed by just operating on these patients. So the journey of this patient, the outcome is determined by exactly how the patient is taken care of at each step of the journey. So what I'm going to talk about is evidence regarding the best practice or the recommended best practice where the evidence is controversial or incomplete. So these things will be based on expert consensus opinion. I'm sure you would come across things being done differently at different places, but what I'm talking about is what things are done most commonly and which has got expert consensus. So intervention, as we all know, starts right from the A&E for a patient who's presenting to us with a fall. So we have to have a protocol-driven, fast-track admission of patients with hip fracture through the A&E departments. This has shown a good improvement in the outcomes. Instead of letting them wait in queues or sitting on them, we know what process and what needs to be done for these patients, so they are straight away rushed to a protocol. Within 4 hours of hospital arrival, hip fracture patients should be admitted to an appropriate clinical ward. Now, imaging options for fractures is simple. You will get an X-ray, but in some patients you find that the fracture is not clearly visible. So the best imaging option for that is MRI scan. In some places you might get a CT scan, but the evidence base is now that MRI scan for the for a suspected hip fracture is the gold standard. If MRI is not available within 24 hours or is contraindicated, then consider a CT scan, right? Now, next thing, as I was saying, all the fractures we think are an orthopedic domain, but no, not the fragility hip fractures. So patients with hip fractures require multidisciplinary approach. And that also not led by orthopedic surgeons, should be led by orthogeriatricians, right? Now, the multidisciplinary team should consist of these various people, at least, if not more. A trauma coordinator, the GP, of course, is always a part of any team. The community falls assessment nurses, emergency staff, physio, OTs, bed managers, orthopedic nursing staff, surgeon anesthetists, orthogeriatricians, social workers, and rehabilitation service. They all are part of the team that will help improve the outcome of the hip fractures, which are going to be a pandemic soon. So all of the people have to be on board to treat these fractures. Evidence base is that dedicated hip fracture ward gives better results. So it will lead to appropriately trained staff. Patients do not move around to multiple areas. That has been shown by evidence to decrease delirium. Now the big six, that is provision of pain relief, delirium screening, early warning scoring, blood investigation, fluid therapy, and pressure area inspection. These all are improved with dedicated hip fracture wards. Pain relief. Now, there is our role basically in this whole treatment of a fracture of femur is this. Surgery is the best painkiller we have. But short of that, we assess and alleviate the pain within 30 minutes of admission, then every hour till settled. This is paramount. NSAIDs are not recommended and opioids should be limited. You should be limited. The star is the most important pain relief thing that we use is fascial acca blocks nowadays. This can be repeated every 12 hours. And this can be given in A&E or should be given in accident and emergency. And do not use nerve blocks as a substitute for early surgery. Next controversy is time to surgery. It's been shown by multiple studies that surgical repair of hip fractures should occur within 48 hours of hospital admission. And for even better outcome, it should be done within 24 hours. So the evidence for that is weak. Pre-operative assessment is mandatory now. So as I said, team effort, anesthetic team role in influencing time to theaters is very important. Then allowing for planning of anesthetic technique, which has got a big importance in the outcome of patient assessment and communication of perioperative risk and pre-optimization. These all things are needed from the anesthetic colleagues. Now, this is an important slide. So these things are to be identified and treated, but not to delay the surgery more than 48 hours. Outcome, as I said, is best if the surgery is done within 48 hours. So these things we try to treat. Anemia can be reversed to a degree. Anticoagulation and electrolyte imbalances, volume depletion, uncontrolled diabetes and heart failure, correctable cardiac arrhythmias and ischemia, acute chest infection, and exacerbation of chronic chest conditions. So we can give up to 48 hours to try to optimize these conditions and nothing else beyond them. Of course, there would be few exceptions, but we should try not to take them in consideration and delay the surgery based on anything else. So nowadays, most of our patients have got some kind of anticoagulation, and that has led to delay in surgery many times. So the consensus in most of the hospitals now, with exceptions of course, is that we do not stop clopidogrel. Aspirin is discontinued, but don't delay surgery because of that. Warfarin, we should have protocols in place to reverse the warfarin to get INR below 1.5. Other anticoagulation agents, you discontinue them on admission, but try not to delay surgery based on if the renal function is fine. That is, if creatinine clearance is more than 30 ml per minute, people have now sort of agreeing to carry on with the surgery without delay within 48 hours with these patients. Now, anesthesia. Consider intraoperative nerve blocks for all patients in recommended surgery. And spinal anesthesia is considered safer for the hip surgeries. Again, some of the anesthetic colleagues don't agree with this, but as I said, consensus is spinal anesthesia for hip fractures. Now you might and you will come across patients who are considered too sick to operate. So should we let them just stay in the bed? That is probably not right. We should still consider them for surgery. There is a role, this is called for palliative care. This will minimize their pain and other symptoms. It will establish patients on priorities for rehabilitation. And you should, of course, consider their end-of-life care wishes. As I said, mentioned earlier, surgery is one of the best painkillers we have for hip fracture. Of course, we should have cardiologists. Now we come to something that will interest us as orthopedic surgeons, the dilemmas with surgical decisions that we take. If we come across undisplaced fractures, what do? Do we fix, replace, or give trial without fixation? There is 30 to 50% risk of subsequent displacement if we give trial without fixation. And current preference in most of the hospitals is that all undisplaced intracapsular fractures should be treated by internal fixation. What should we do if there's an intracapsular fracture which is not very displaced? Should we go ahead with dynamic hip screw fixation for minimally displaced fractures, or should we give multiple screws? So there is weak evidence that DHS has better outcome, and it has got biomechanical advantage over multiple screws. Intracapsular fractures in young patients, what do you do? Fixation irrespective of displacement? Yes. So in young patients, even if it is completely displaced fractures, you go ahead with trying to reduce them and fixing them. Now, what is the cutoff age? That's a controversy. Anywhere around 50 would be my cutoff age, but it depends more on their physiological age. Elderly patients, what do you do for a minimally displaced intracapsular fracture? Fixation or arthroplasty? This is based on multiple factors, sorry. Patient's physiological age mainly, and displacement of the fractures. We continue with controversies in intracapsular fractures. Which is better, hemiarthroplasty or total hip replacement? Now, we all are aware that NICE is pushing towards total hip replacements. We have to take a decision based on the patient. Each patient has to be taken on their own merit. They should be independently mobile with intact cognition, and they should be medically fit. And then they want a total hip replacement. Age is not a factor there, you should know. Then hemiarthroplasty, which should be used, cemented or uncemented? Cemented stem has been shown to increase fat embolism and leading to cardiopulmonary complications. But uncemented stems are known for periprosthetic fractures, and they are known for inferior functional outcome scores. So the consensus is to try to use cemented stems in fractured femurs. As we said, this is a dilemma everywhere for total hip replacements, and still stands true for patients who are undergoing surgery for fractured hip. Whether we do cemented, uncemented, or hybrid. As I said, my preference personally is cemented, but there is no strong evidence for either of them. Head size, should it be 28, 32, 36, or should it be higher? And should we use dual mobility for total hip replacements in fractured nerves? That still stays controversial. Now, head size. Now, how big is big enough? We all like to put big heads to prevent dislocation. That is the common myth we have. But we know that large head sizes lead to volumetric wear, and there is elevated metal ions, as we know from our experience from metal-on-metal hips and hip resurfacings. There is ongoing concerns about ALTR lesions and ALVAL lesions. There has been shown to be no benefit in hip function when the head size is more than 36 millimeter. That's been proven. But long-term total hip survivorship with weak evidence has proved that 32 millimeter heads are the best, with, of course, X-linked polyethylene bearings. This is better than smaller and larger ones. Now, dual mobility or a conventional hip. Again, dual mobility is a good concept. Looks like it would help in decreasing the increased rate of possible dislocation that is present in total hips after fractured nerves. But early designs of dual mobility had their own complications. But the newer generation dual mobility prostheses are demonstrating these problems have been overcome. The evidence hasn't come to be very sure yet, so it's still needed. Approaches, of course, various approaches have been described, but there's an expert consensus again that anterolateral approach is favored over posterior approach when doing hemiarthroplasties. Extracapsular fractures, they have their own dilemmas. Now, for AO classification, A1 and A2 fractures, which are fractures which are above the lesser trochanter. The DHS, that is, or a sliding hip screw, is preferred to an intramedullary nail. This has been impressed upon us by NICE also. But we use intramedullary nailing when there is compromised medial calcar via comminution, or a large posterior medial fragment, or fractures that extend into the subtrochanteric region. Of course, reverse obliquity fractures, transtrochanteric fractures that involve the lateral cortical wall. They all warrant intramedullary nails do better in them. These are a few examples of these fractures. The subtrochanteric extension with reverse obliquity, the lateral wall comminution, and subtrochanteric extensions. When we're using nails, there's again decision to be made about whether we use short nail or a long nail. In some studies, it has been shown long nail prevents refracture of the femur because it's the osteoporotic pathological fracture which we are fixing, and the tip of the short nail has a possibility that refractures can happen there, or as such fractures can happen in the femur because of osteoporosis. And it's been shown that post-op hip and thigh pain is less with long nails. Now, there are some measures we can take intraoperatively, like tranexamic acid. There's evidence that it helps in reducing bleeding. Local anesthetic injection, fascial LACA block, I've already stressed on that. That can be done intraoperatively. And increasingly, in some trusts, they're using these devices, which are continuous infusion local anesthetic pumps. The evidence for them is lacking. When to weight bear? Invariably, the consensus is the aim is to the whole process. We have been doing everything we have been doing so far, surgery, letting them, optimizing them for the surgery, and everything has been done just for this purpose, so that we can allow them to weight bear and walk without restriction as soon as possible. So we should not defeat that purpose by not letting the patient mobilize as soon as possible. So offer patient physiotherapy within 24 hours unless medically or surgically contraindicated. Cognitive assessment is important. That should be part of the hip fracture treatment. Nutritional assessment and fall prevention are other things that are important. They cannot be overlooked. Post-operatively, physiotherapy, as I said, reduces risk for bad bed-bound complications. Also look at the fragility fracture risk. It should be done with the help of our medical colleagues. And of course, data collection. We know that UK has got a national hip fracture database that has been instrumental in changes of all our practice. We have made small changes in our practice, but they have all had important outcomes in the results we have been able to produce for our hip fracture care. And of course, audit and data should be priority in our practice, which sometimes gets missed. Thank you. Thank you, everybody. Thanks for your patience. As I said, a very common topic, very simple topic, but common things are common both in your medical life and also in your exams.
Thank you very much, Mr. Sharma. That was a really nice walk through the hip fractures and the best practice tariff, which is a common topic in exams, and it's a topic that you can't afford to get wrong. You do need to know this in detail. In some ways, you know, you think it's an easy topic because it's something we deal with every day, but in fact, you need to know the guidelines and exactly the details that Mr. Sharma's outlined in that lecture. So, are there any questions? Hani, do you have any questions?
Yes, so
Beautiful.
someone asking about the paper which says the DHS is better than the screws.
Sorry?
The paper that says that the DHS is better than the screws?
I can provide the exact papers. I mean, as I said, most of these evidence that we have produced, you would come across some papers which have said that they're both equally good, but there are few papers that are suggesting that the DHS has got a better physiologically more structural support to the proximal femur to allow early mobilization. Exact papers, if you drop me your email address, I can find out and send to you.
Okay, so just a question. So what is the criteria to say I will do DHS here in this case? No, DHS, I couldn't do that. I will do nail.
All right. Shall I take you back to my slide?
Okay.
Right. So if we look at our extramedullary fractures, extracapsular fractures, they're divided in AO classification A1, 2, and 3. So 1 and 2, we should invariably do DHS. We can do intramedullary nailing also, but the evidence base is that DHS does equally well with A1 and A2 fractures. The outcomes is equal. In some papers, they have suggested that there is decreased blood loss and decreased operating time with DHS, which is controversial, but it is equally well in A1 and A2. Now, if we go beyond that to these things that I've emulated here, where compromised medial calca, you should are in favor of intramedullary nailing. Of course, if there is subtrochanteric extension, intramedullary nailing, large posterior medial fragment, intramedullary nailing does better. Reverse oblique fractures, intramedullary nailing does better. And transtrochanteric fracture that involve the lateral cortical wall, right? And these are a few of the examples. Like if you get a fracture like that, this is a typical example of reverse oblique fracture. This is comminuted calcar and also subtrochanteric extension. The lateral side here is blown out. Again, this patient has got a subtrochanteric extension. So some of them might still be fixed with DHS, but outcome would be better with nailing in these ones.
Okay. So actually, there is a paper published in 2016, and they mentioned that if you draw a line about 3 centimeters below the inferior end of the GT, and you measure the distance between this point to the fracture line, if it's less than 2 centimeters, you shouldn't do a DHS. What do you think about that, Mr. Sharma?
So to draw a line from greater trochanter.
Yeah, from the inferior, the distal part of the GT, about 3 centimeters distal to that, and they measure the distance between this point and the fracture line. So you need 20.5 millimeters of the lateral wall to do a DHS.
Yeah, I mean, you can still do DHS for them, but this is now, we are going to the area of subtrochanteric, or which inherently, as I mentioned, subtrochanteric fractures don't do well with DHS. There's the DHS is based on a principle of controlled collapse. So it does need to collapse onto something. The fracture needs to collapse onto something. If there is no support to collapse on, like the lateral wall, then the pressure would go 100% on the plate. So it's more likely to fail in that situation. Whereas the nail inherently, because it is the fulcrum wise, it's more nearer the fulcrum or the center, it's more likely to function better in that situation.
Okay. There's no more questions.
Okay, thanks, Hani.
I'm surprised because every slide of mine is full of controversies.
Yeah.
This is, as I said, the commonest topics have got many controversies. You wouldn't even understand a simple hip fracture. We walk through so many controversial decisions, but this is just to evoke your interest in how many controversies we traverse every day. Well, best of luck, everybody, for your FRCS.
Thank you so much, Mr. Sharma. On behalf of everybody else, thank you for giving up your time today and educating us all on that topic, which, you know, it's like diabetes in medical school. You think you know it, so you don't learn it. When in fact, it's what's going to trip you up in the middle of an exam, and then you'll be kicking yourself afterwards. So thank you so much for joining us.
Thank you, Mr. Sharma.
Thank you. Take care.
All right. Thank you. Okay, guys, so I'm going to stop the recording and we will move on to the Viva section. Give me 1 minute.